do, please join me in welcoming Dr. Susan Nyanzi, who will address the challenges scleroderma patients face when admitted to the hospital. Take it away, Susan.
Okay, thank you so much for such a great such a great introduction. So I need to put my screen up. Okay, hold on. Okay, can you see it?
Yes.
Okay. So again, I'll just go over what the initials mean after my name, and Tina touched on all of them pretty much. So it's a Doctor of Public Health. So it is a PhD, but this one has a practice component to it. So in addition to doing teaching and working in universities, I also have like a clinical side, the practice side of it. And then the MCH is the Master Certified Health Educator Specialist. That's the highest you can go. And it is a designation that you get when you do community-based interventions. In other words, you need to understand, behavior change, health education, and how you can put all of that together into a program. Then I'm also a member of the American College of Sports Medicine. So that's kind of related with exercise physiology, kind of understanding and knowing all of that. And then the last one is the fellow research. I know I should remember this. Can't remember it, but it's similar to the MCHES, but that is the British equivalent. And of course, I grew up in England, so I need to have something from England. As Tina said, my specialty is chronic disease management, and it's chronic disease management through lifestyle. So I don't prescribe medication or tell people to take medication. All of it is through lifestyle, and I teach as well. Okay, so kind of looking at the big picture before we talk about the challenges we face as patients, ideally, your hospital stay, you get admitted to the hospital by one of your doctors. The doctor there at the hospital is supposed to find out what's going on, what went wrong, and then he develops a treatment plan. And of course, in that treatment plan, he includes you in the decision-making process. If you have concerns, he addresses those. And it also has to be scleroderma friendly. So this is a big one. Many of the doctors, since they don't know scleroderma, they will not think of it as how it would impact a scleroderma patient. And that's where we need to be really particular and make sure that it is. Okay, so we make sure it's scleroderma friendly, then the plan is implemented without any issues. You get well, you go home, and ideally, that's how all hospital stays should be. But of course, as many of us know, that is not always the case. Okay, so why should we advocate for ourselves? So we all know scleroderma is designated a rare disease. So our numbers are really small compared to other conditions. And so because of this, many physicians don't have experience taking care of scleroderma patients. They don't know what could go wrong. And I'm sure you've also heard this when you've been in the hospital or gone to a clinic somewhere, and then they will say, oh, I remember hearing about scleroderma in medical school. And then majority of them are not going to know the updated treatment protocols. And they're going to educate themselves by doing like a five-minute Google search. Now they have to go through all of what is on Google and find out what is the reputable, the right treatment and which one is the wrong one, which one is the old one. So they need to make sure in that 5 minutes, they get the accurate information that they need. And that might not be the thing that they really find. And then the other thing, they think we don't know that much. And generally speaking, scleroderma patients know more about their disease than other patients. Okay, so now we look at the nurses. And this is again from my experience, and I'm sure I'm sharing something that most of you have also, experienced. Most nurses have never heard of scleroderma. So they won't know what to do. And this is where it's a great opportunity to kind of teach them about scleroderma. And the ones I've met always want to learn. And so I share about how scleroderma has affected me. And I always have in the back of my mind that I'm preparing them for the next scleroderma patient that comes through. So for an example, over 4th of July, I ended up in the hospital, and the ER nurses had seen some scleroderma patients. So they saw I was a scleroderma patient, and they go, you're very different from the regular scleroderma patients we see. Does that mean your scleroderma has really progressed? So I had to kind of flip it around and go, well, no, not really. I'm just going to explain how scleroderma has affected me. And so I went through, the explanation of how scleroderma has affected my GI. And they really wanted to learn and really wanted to know. So, shared that. Now, the other reason we want to advocate for ourselves, we want to make sure we don't get worse in the hospital. We want to make sure they don't do unnecessary tests or give us unnecessary medications, because they will. And then we want to make sure we lessen our stay in the hospital. So we understand what we need to do. And I go, okay, well, let me see whether the literature, the scientific literature, talks about how to take care of scleroderma patients in the hospital setting. And there was a lot of information that I found, but there wasn't anything that looked at how to take care of scleroderma patients in the hospital setting. Couldn't find anything on that. But what I did find is there were a lot of articles that looked at scleroderma patients passing in the hospital. Now, this doesn't mean it's going to happen to you. It just means this is what the doctors are seeing in the hospital. And I'm going to touch on two studies, the most current ones, and the big studies that looked at this. So the one study had 48,655 hospitalizations. So this was done in 2018. So it's big, it's big. And in this study, that's where they saw that the rate of scleroderma patients passing in the hospital was 5%. And then they also found that infections were the primary diagnosis of people coming in. And it was also the primary diagnosis of people dying or passing in the hospital. The other things that increased the risk of passing in the hospital was if your kidneys were not working well and you aspirated while you're in the hospital. And then the average length of stay was about 4 days. So that is one big study. Now let's look at the second big study. So this one is done at the University of Pennsylvania in the hospital then. Now, they looked at factors that predict passing in the hospital. So at the time, the things that predicted passing in the hospital were a history of lung disease, again, kidneys not working well, anemia, and aspiration. So there were a lot of articles on this topic that, went back like 10 years. What this is really saying is that this topic is a concern for researchers. So they're seeing, really, maybe not a pattern, but they're seeing that a large percentage of us are passing in the hospital. So our part as patients, we need to make sure that we've been taken care of the right way. And I'm not saying this is going to happen to everybody. I'm just saying it's good that we see what the literature is saying. The scientists are saying this is of concern since there's a lot of articles on it. So that is really just telling us as patients, we need to make sure that we've been taken care of the right way. Okay. Okay, so now let's look at preparing for surgery. So I'm not talking about colonoscopy, endoscopy. I'm talking about a major surgery. So the usual protocol, for healthy people who don't have a chronic condition, you meet and you talk with the surgeon. Then you meet with his nurse. You go through the protocol of the surgery and everything. Then you go home and wait for the surgery day. Okay, that is for the regular person. Now, for us, scleroderma patients, we need to put additional steps in there, and we need to strategize that everything is going to go well. So we need to talk to the right people. Tina, with her experience in scleroderma, knows who would be helpful to you when you go for your surgery. So these are the steps I did. And she was the first one I talked to. And she suggested who I should talk to, who would help. So of course, I talked with my rheumatologist first. He or she are going to know what you should tell your surgeon. And they will also think through the steps of other things to take care of. So the first one is medication interactions. At the time, I think I was only on 2 medications, so I didn't think that was a big deal. But my rheumatologist was, that's some big medication you're on. You better check the drug interactions on that. And I'm like, no, the pharmacist will take care of that. I'm okay. He's like, no, I think you should do it. Okay, I do it, and I find a drug interaction. So, okay, I'm going to go and tell the nurse. I tell the nurse tells me, most probably that's a small interaction compared to the benefits we'll get from this other medication. So, just bite the bullet and we'll just go with it. And I'm going, no, I think we need someone else to check with this. Maybe we should check with the pharmacist. Okay, we check with the pharmacist. Pharmacist calls back, oh yeah, that's a major interaction. We need to give you a different medication. So if you don't bring it up to them, they're not going to look at it. So it's best that you also do your homework and then bring it up to the nurses or another decision maker so that the pharmacist will look at it. Okay, so my rheumatologist also said, okay, you have some secondary conditions as well, like Raynaud's. Make sure they know that as well. Okay. So I say, okay, that's fine. Next person I talk to is Elaine first. And with Elaine, she will systematically go over the scleroderma limitations you have and see whether they'll interfere with the surgery or make it difficult for the surgery. So the main one, most of us have a small mouth, limited range of motion in the neck, and we also have Raynaud's. So why is that important for when you're going for a surgery? Well, they need to intubate you. So in order to do that, you have to have wide mouth, you have to have a good range of motion in the neck so they're able to intubate you correctly. And so I realized that might not happen with me. And the hospital I was at, you could actually go and make an appointment in the anesthesiology department and share your concerns with the anesthesiologist there, and they will share it with the anesthesiologist that's going to be part of your team when you go into surgery. So I go in, I tell the attending, my small mouth, limited range of motion in the neck, and I also tell him I have Raynaud's. Okay, he looks, he measures. Okay, he's going to tell his boss, who's the head of the department. The head of the department comes in. He's like, oh yeah. So, okay, we see you've got a small mouth and limited range of motion in the neck. Okay, we can address those. And at this point, I'm thinking, okay, no one is talking about Raynaud's. So I tell him, oh, I also have Raynaud's. So the head of the department pauses and goes, okay, that's a big deal because you could get hypothermia. Okay, so I need to tell the anesthesiologists to warm up all of the fluids and the gases they're going to use on you. So again, what I learned, what I tell the attending physician or the resident, I also have to repeat again to the main doctor because he'll have more, he will understand what else could go wrong. Okay, of course, the other person you need to talk to is the surgeon. So my surgeon didn't know about scleroderma. So once again, told him what my limitations were, how scleroderma has affected me, and I mentioned I have Raynaud's. Again, he takes a pause. That's an important one. Yeah, you better tell everybody on the team what you have. So I now have a paragraph that I've constructed that I'm telling everybody on the team what I have, so everything is prepared correctly. Okay, so that was preparation for the surgery. Okay, so you're also in the hospital now. So you also need to prepare for the hospital stay. And the thing that is really important, you have to make sure you have your medication list. You want the name of the drug, you want the dosage, and how many times you're taking it. Again, if you're taking supplements, over-the-counter things, and herbs, you have to tell them so you can avoid drug interactions. They won't look for the drug interactions until you tell them everything that you're taking. So with me, I'm intolerant. I have an intolerance to corn, dairy, gluten, and they put these compounds as binders and fillers in all medications. So I can't take regular medication. All my medication has to be compounded. So when I'm going in, I take all my medication from home, all of it, and I take it with me to the hospital. and they will give you your own medication. Okay, now the other thing you need to have, important phone numbers to have. So in speed dial, you want your rheumatologist office number there. If you have a home health nurse, I do because I have a PIC line. I have his phone number. I have my mother's phone number. She's a physician and she used to fight for me when I was younger in the hospital. So she understands what's going on. So I have both, then all three numbers at easy access because you're going to be using those numbers during your stay. And we'll talk about that in more detail. Okay, the other thing that's going to be really helpful, you need to be well versed with how scleroderma has affected you, because you know more about scleroderma than the care team you're going to have in the hospital. So make sure you know exactly how scleroderma has affected you. You know, talk with your rheumatologist to make sure you have the details and what you have. Now, you also, with me, I have nutrition limitations. So I have that written down. So some of us might have swallowing problems as well. Write all of that down. For me, I have gluten issues and some swallowing problems. So I wrote mine down. Again, if you have secondary conditions like Raynaud's, write that down as well. And I have an example here. So I was in the hospital again, and I had come in with the fever. And anyway, they admit me, and the nurse who was taking care of me, so I had a fever. She's, oh no, you have a fever. I need to get this room cold to get that fever down. I'm like, yeah, no, I have Raynaud's. I might end up with a Raynaud's attack. So no, don't touch the air conditioning. She took off blankets off me. She put the air conditioning down. I pulled the blankets back. Thank God the attending came in early. And I said, before we do anything, we need to change the temperature of the room. It's too cold. I have Raynaud's. So he was, oh my God, we have to switch that down. And I said, the nurse is putting it on because she said she's trying to get my fever down. He's like, no, that's not how you get a fever down. I need to give you medication to get your fever down. We need to get that temperature up. So he called the nurse back into the room and told her she has Raynaud's. We're going to end up with more complications. Put that air conditioning back up. So she had put it down to 65. I was like, put it up to 80. So they put it back up to 80. Okay, so that's the example. Okay, so now we need to come up with the list of things we're going to tell the attending or the hospitalist. So we need to remember why we were admitted. So usually you should have talked through this with the physician who sent you in, and you kind of have an idea of why you're admitted. Okay, we have to show them the current medication list. So again, we need to know how our pills look like because they're going to add other medications to your regular regimen. The main one they add is Senokot. That is for constipation. It's a laxative. And my point is, if you're using a laxative, take the one that you use instead of the one that is provided to you. Your system is going to be used to the one you usually take. Okay. The other thing they also suggest, or sometimes they will say, oh yeah, instead of taking medication, take a high fiber diet. So this one, I refuse because my rheumatologist told me the high fiber diet is going to act like a plug. And I looked it up in the literature, and there were actually papers that talked about case studies of scleroderma patients that were told to take a high fiber diet that had to be hospitalized to otherwise unplug them. So that one we run away from. The other medication they give you is heparin, and this is to prevent blood clots because most patients are just going to stay in bed and they're not going to move. So you don't necessarily have to take that. If you get out of bed, walk for 20 minutes, 2 or 3 times a day around the hospital ward. If you're not able to walk, you can do some chair movements, chair exercises. So at my last hospital visit, I was doing chair exercises to keep things moving. For me, when I take heparin, the injection site, there's blood oozing an hour or 2 afterwards. So for me, it doesn't work. So I'm giving these suggestions just to make sure you have different options. So I'm not telling you to do it, but see which options work best for you. And there are different alternatives you can do. Okay. So again, we're still putting our list together of what we're going to tell the attendant. So we're going to tell them how scleroderma has affected you. With me, I have nutrition limitations. He should be able to do a consult with the dietitian who can come to you. And again, let them know, the physician, the hospitalist, that you can't do high fiber diets. And you can't do high fiber diets. And if you have really severe food limitations like myself, I had someone in the kitchen go to Whole Foods and get food that I could eat. So they can work out solutions for you that are doable. And again, at my last day as well, the head of the department saw I was having a hard time with the food that they were giving me, and I couldn't eat it anyway. So he even said, I can go to Whole Foods and get you something. So they can always find a solution to help. Okay, so all of this might sound repetitive. And you want it to sound repetitive so that everyone that's taking care of you remembers it. Okay. Okay, so now your provider or the physician that's taking care of you should explain what they're going to do and how they're going to move forward. If it doesn't make sense to you, you ask questions. So each step that he tells you should be detailed enough that you know what they're going to do. They should explain their treatment plan. Again, if this doesn't make sense, you need to ask questions, and it has to be very specific. And if you have concerns, tell him as well. And he should address these in the treatment plan to make sure that it's scleroderma friendly. In the end, after you've all spoken, both you and the physician should agree to the treatment plan. If you don't agree to the treatment plan, he needs to alter it to make sure that is going to work for you. So after he gives you the treatment plan, you talk to your rheumatologist, check that out. You talk with your nurse to check that out. And if they both say it's okay, then you agree to what they're suggesting. So now I'm going to go over some examples to kind of highlight what I've been talking about. And I'm going to start off with the ideal hospital stay and ideal approach. So this is the team approach. Now, all hospitals, okay, I'll talk about the ones that I know. The one I go to at UCLA and my local one, they're all about team approach, which means the patient is included in the decision process of the treatment that they get. So the physician should be explaining what's going on. Then they should discuss treatment options. And then from those treatment options, they can suggest which is the best one with all of the other conditions you have, and then give a good reason why. So in my example, when I first went to the hospital in LA, I had a team of doctors. I had 5 specialties all coming in, explaining what's going on, because nobody could tell what was going on with me. And then they talked about what were some options. And the other thing they did, the 5 subspecialties, they all talked with each other to find out what was the best option for a scleroderma patient. They had read up on scleroderma, they had read up on my history, and it was really a discussion on what was the best option for me. They included me in the decision process. I even suggested some articles. Tina helped make some copies for me. I handed out the articles. We all talked and found a solution that could work. That's how it should be. So you shouldn't be feeling stressed. You shouldn't be feeling bad. Things should be working smoothly because they've also thought about you as a scleroderma patient. Okay, the second example. This is the approach the doctor used at my last visit, and it was authoritative approach. Do as I say. Now, he didn't give me a detailed plan. He kind of just gave me bullet points of his plan and told me, this is what we're going to implement tomorrow. We didn't discuss how it could affect me with scleroderma. So it kind of sounded doable, but I wasn't feeling well with it. Kind of sounded too simplistic. And I'm like, I'm going to check with my nurse. My nurse has been in the TPN world for 10 years. So I explained the approach this doctor's taking. The nurse didn't like it. And he explained how it could be painful for a scleroderma patient. And he gave me another alternative that could be used. So, I question the plan again. I tell the nurse, I need to talk to the physician again because I'm having some concerns about the plan. Okay, brings in the physician. Again, I tell him my concerns, pretty much what my nurse has told me. He comes up with more vague solution, well, not solution, vague answers to support his plan. I'm like, okay, I guess it sounds doable. And the infectious disease team was supposed to come in, remove my PICC line, and cure the infection for 3 days, and then put a new PICC line in. So when the infectious team comes in to remove the PICC line, that's when I'm going, I wonder if they've thought about how I'm going to get my nutrients once the PICC line is out. So I'm asking the infectious disease doc, how long will the PICC line be out? How am I going to get my nutrients when the PICC line is removed? Because I get 70% of my nutrition through the PICC line. They hadn't thought of a plan of how I was going to get my nutrients. So I picked up on that, and I refused or stopped the process of removing my PICC line. And I said, I need to see a plan of how I'm supposed to get my nutrients when the PICC line is removed. And you can do that. You can stop things. So I stopped it. And now, and actually, before I stopped it, the infectious disease doc was trying to tell me I could survive without nutrients for 3 days, and I should eat more of the regular food. So again, those are not going to work. I get hypoglycemic because I'm not going to have all my nutrients. I'm not going to have enough calories. I would end up being hypoglycemic. They would have to treat that. And then they would have to figure out how to give me nutrients so I'm no longer in hypoglycemic state. So this just told me that this infectious disease doc did not read my history, did not understand how the PICC line works, and didn't have a plan of how I'm going to get my nutrients without the PICC line. So they had to figure out a plan on how I'm going to get my nutrients once they removed the PICC line. Okay, so I've just gone through all of this. So after I refused it, I called my nurse again and I told him what happened. And he said, I did the right thing. So the point here again, make sure you have detailed responses to your questions. And as I've put here, I would have ended up with hypoglycemia, dehydration, and they would have to figure out how to get nutrients with me when I'm in a hypoglycemic state. So this doctor did not think through all of her steps. Okay, so this is a next example, unnecessary testing. And again, this is where you need to know your condition really well. So the resident hears me coughing. And he asked the regular questions, which I'm used to. Then he asks me another one. Where are you from originally? I'm like, they haven't asked me that before, but okay. I'll go ahead and tell him. So I'm like, yeah, I'm originally from Africa. And then he goes, we need to test for TB. Okay, what? So for my Black, brown sisters and brothers, this is an example of implicit bias. Implicit bias means we have attitudes towards people or associate stereotypes towards people without our conscious knowledge. And in this example, the resident just heard Africa, just heard Africa, then associated that with TB, and then wanted to test me for it. So of course I refused. And then I gave him this example. I haven't been to my country in 45 years. And when I left my country, I moved to England for 15 years. And then from England, I came here to the US, and I've lived in the US for 30 years. That's really telling him, okay, we'll play his game. So assume I had TB. I was in England for 15 years. The English were that stupid and ignorant not to pick up on the TB when I was there. Then I came here, and I've been here for 30 years, and none of my doctors could pick up that I had TB. I guess my sarcasm was too much for him. He didn't get it. And what was really happening, and I knew it was my asthma, I was coughing because I had asthma. The temperature had dropped in the room. The coldness triggers my asthma. Okay, another example. Looking for massive blood loss. Again, this is where it's important to know how scleroderma has affected you. So another hospitalist comes in, is telling me, oh, your hemoglobin is dropping. You're losing blood somewhere, and we need to find where it is. And I'm going, yeah, no. I have scleroderma. It's affected my GI, and sometimes I have blood oozing in the intestinal tract, and I have to have iron infusions every year because I lose blood that way. And then also, you've been taking blood from me 2-3 times a day, and you're using big syringes. So I think I've got hospital anemia. No. Your levels are really, really low, and I have to follow hospital protocol. So now I have to give you a blood transfusion, and then we'll see how it goes from there. I'm like, yeah, no, you're not touching me. I need to talk to my rheumatologist to really find out what's going on. So call my rheumatologist, tell him what's going on. Call my nurse, tell him what's going on. Call my mother, tell her what's going on. So they all agree that most probably they've taken too much blood, and my GI is oozing some blood due to the scleroderma. But they all agree I need to take the blood transfusion. Okay, so I take the blood transfusion. At the end of it, the hospitalist comes back, and your numbers look really good. So probably you don't have massive blood loss, but most probably it's your GI and the hospital anemia that caused the drop in your hemoglobin. So again, make sure you know how scleroderma has affected you. Okay, so this one, I called make a run for it because I really did. So I got admitted to the local hospital, and I'm telling them, I've got scleroderma, but I was having really bad GI issues. So in a month, I would be hospitalized several times. I'm like, okay, I can't live like this. Something is going on. I couldn't walk. I had bad vertigo. My labs were just always off the charts. And so the GI doc eventually admits me again. And, he's saying, oh yeah, I've had scleroderma patients before. I know how to work with scleroderma patients, and I also have contacts at Cedars. So if things were to go wrong, I can always call Cedars and they'll give me examples. Well, he did test after test. Nothing came out. Then they did 2 colonoscopies in 2 weeks. That came out normal. All the tests that we're doing wasn't coming out right. I mean, they were coming out as nothing was wrong. And I remember my mom even suggested, obviously there's something with her gut because she's lost 40 pounds and there's no way I should be losing 40 pounds. And the GI doc kept pushing back. Actually, my mom suggested a feeding tube. And the GI doc kept pushing back. Yeah, no, that's not the right thing to do. It wasn't the right thing to do for him because he wasn't well versed on it. So for him, it wasn't a good idea. But eventually, that's what UCLA put me on. And so when some of the doctors are pushing back, we need to figure out, is it really, they're saying no because it's really in our best interest, or they're saying no because they haven't done it in a long time and they're not well versed in it. Okay, so this time I'm in hospital once again. Hospitalist comes in and tells me, we've been doing all of these tests. They're all negative. That's because they were doing the wrong tests. And then he tells me, we're going to discharge you to a care facility. I'm going, no, I'm not going anywhere. I still can't walk. I have vertigo. And my electrolytes are all over the place. I'm not going. So he keeps pushing me, telling me he's going to start the paperwork to discharge me. And that he's going to talk to my rheumatologist and they're going to come up with the plan of where I should go. Of course, I'm saying no. So he leaves. I call my rheumatologist and explain what's going on. And so the rheumatologist asks me questions and he goes, your body is in starvation mode. You need to come here now. I'm like, okay, how can I come here? He goes, yeah, you can order an ambulance and these are the steps of what to do. I was like, okay, I'll go ahead and do that. So 2 nurses had seen what was going on. And so they became friends and allies. And so I tell one of them, I'm going to need all of my paperwork before I go to the other hospital. And I remember Penny used to tell us this, that make sure you have all your paperwork with you and take it with you when you go to the hospital, if you're changing hospitals, because that one hospital might not send all of your paperwork. This nurse collected all of my paperwork, my history, put it in a folder for me, brought it to me. Another one started the ambulance request process. And that's how the GI doc found out that I was trying to leave. So he comes back angry that I'm leaving. And I'm telling him, you know, my doctors in LA are saying I really need to go there. Well, he stops the ambulance request, stops it. You know, an hour goes by, like, nothing is happening. You know, after half an hour, I call my rheumatologist. I'm like, what happened? He goes, someone at your end stopped the ambulance process. And this time I'm like, okay, this doctor is really not wanting me to leave and making it very difficult. So my rheumatologist says, do you have a family member who can bring you? I'm like, yeah. He goes, okay, dress like this. So he tells me how to dress, tells me what to say once I'm in the ER. I'm like, okay, I'm ready. Tell my cousin comes, takes me to the hospital in LA. And just as we were leaving, I guess the GI doc felt bad. Then he says, you know, I don't want to get in the way of your treatment, so I will discharge you. But just to let everybody know, you don't need them to discharge you. You can leave on your own. Okay, so we've talked about all of these examples. Now, what can we do as patients to make sure conditions improve? So with hospitals, satisfaction surveys or letters are very important. Just as important is the dissatisfaction letter. So we need to remember how situations happen. So in all of the examples that I gave, I sent a letter to, they usually have an office where you can send these letters to. So I explained all of the details. I put titles in there of the people who were not treating me right or who didn't think through steps, wrote it all down and sent it to the office that takes care of these letters. Now, why I wrote those letters was really thinking about the next scleroderma patient that comes in. And then when you write that letter, they suggest that you also give solutions as well. So I wrote down what happened and I gave solutions. And I think I even put in there that they didn't know how to take care of scleroderma patients. And I made that the main point, and I sent the letter. So once they get the letter, they give it to the people that are involved. And those people have to read the letter. Now, some of them can say they want to talk in person to explain, you know, what really happened. But then the office also asks you, do you want us to put this on their record? I said yes. And they explained that if we put, you know, the letter on their record, then if something similar comes up again, they can look in the provider's record and see that they've done this before. and it can look like a repeated behavior. So if we keep silent, we're allowing suboptimal care to continue. But if we send these letters, and they're constructive, but we have to continue sending these letters when things go wrong. So the example. So one of my examples, I talked about the resident who was using implicit bias to do an unnecessary test on me, the TB test. So I explained what he did. I gave the definition of implicit bias, and then I included in there a training that could be done that could help address implicit bias. How did I know about this? It's because at my work, during the beginning of summer, we had taken several courses on implicit bias. And so I wrote the name of one of the people who did the training for us. Okay, so that's it. The other thing I've added on here is a link for the FDA webinar that we did. They have a docket where patients can still go there and give their story. It won't close until December 15th. So please, I encourage everybody to go in there and share their story. It will be good if they could see a whole range of scleroderma patients, and hopefully they can help develop new drugs that can address some of the issues we have and hopefully eventually end up to a cure. So I'm open to questions now.
Thank you,
Thank
Susan.
you.